I'm going to go ahead and get started today. We are fortunate to have Dr. Compton coming and talking to us today about the prevention and treatment of type 2 diabetes. And I'm going to have Dr. Compton introduce himself, and we'll get to know him a little better and hear what he has to say. Thank you, Dr. Compton.
All right, thanks so much, Melissa. Appreciate it. So I'm Dr. Compton, recent graduate from Loma Linda Family and Preventive Medicine residency. So I did a dual residency, and now I'm out here on the north side of LA up in La Cañada. And I'm sure some of you know where See's Candy is, right? Up on Foothill Boulevard. My office is just that next section of buildings, just down the hill from See's Candy. Usually people in this area know where that is, but I thought I'd throw that out there. And yeah, I'm excited today to talk about prevention and treatment of type 2 diabetes. You know, I almost put prevention and reversal of type 2 diabetes because I do believe in diabetes, at least type 2 reversal. And that's what I'd like to talk a little bit about today. I'm going to go ahead and switch my screen here and tell me if you guys can see this. I just wanted to introduce my family here. Can everybody see that? Maybe Melissa, can you see this?
Yes, yeah.
All right. So this is over. This is over in Azusa Canyon. Is right behind that. This is the San Gabriel River bike pathway. I see some joggers on there, but it's mostly bikers that I see. And what you'll see is my oldest boy in the Fox jersey. And then you see my middle son next to him with his hand up in the air. And we went out with cousins, but my third son, just 3 years old, he's wearing the R2-D2 helmet there. And he's got his cousin kind of helping him stay steady in the red wagon there. Anyways, we had a great time. This was just a couple weekends ago. This is something I like to do. I thought I should share that. A little something about me. But let's dive into this. And just have to pull my controls here. There we go. So the question is how can I prevent or treat type 2 diabetes?
Hi.
And
How are you? I'm good.
I'd be happy to have anybody interrupt me if I'm using medical jargon or using a medical word that just doesn't make sense. Feel free to type it in the chat box. I can see it in the chat box right now. And so speaking of which, diabetes is a medical word. And to be clear, I'm going to be talking about type 2 diabetes, not type 1. Type 2 diabetes is essentially an inability to tolerate carbohydrates. And it happens when one's cells and their tissues lack a sensitivity to insulin. And that's called insulin resistance. The insulin that your body makes is just not doing its job. And we're going to talk about some of the medications that are used to help it do its job, and also some of the things that we can do to get it back acting a little more normal. Now, in 2009, the CDC reported that over 75% of our healthcare expenditures, nearly 80%, was due to chronic illness that was really largely preventable. And they said that almost all of the chronic illness out there can be eliminated. I think they said 80% can be eliminated by reducing 3 risk factors: physical inactivity, smoking, and poor diet. And in fact, they said that 40% of all the cancers out there could be reduced by these things as well. I have shared this slide before, but there are several layers that we'll talk through in terms of how we treat diabetes and how we can prevent it. There's the surgical approach at the top of this pyramid. There are prescriptions. There are some physiology things that can be done. And the main thing, the base of the pyramid, the foundation of the pyramid, is lifestyle and treating disease, chronic disease. with lifestyle. And I'm going to basically answer the question right now for the whole presentation is, what can I do to prevent or treat diabetes? It is to be physically active, eat healthy, and maintain a healthy weight. It's simple. It's more simply said than done, obviously, but that's the crux of diabetes management. Are those three things. And I want to talk about some of the background and kind of dive into this topic a little bit more. We'll talk about carbohydrates, insulin, what the pancreas does, something called a GLUT4 transporter, and then gluconeogenesis, and we'll define each of those. So what are carbohydrates? Carbohydrates, you'll see that on the left side we have sucrose. Sucrose is just regular old table sugar. That's what you add to your cookies and your pies to make everything sweet. That's sucrose. And sucrose is actually comprised of two different simple sugars, glucose and fructose. Fructose you find in greater amounts in your fruits, whereas glucose is the main thing that we measure in your bloodstream when we're looking to see if you have high blood sugars during diabetes. So I use it interchangeably, high blood sugars and high blood glucose. I mean the same thing because I'm talking about your glucose levels. Starches, you'll see on the right-hand side, are chains of glucose, carbohydrates, simple sugars, all packaged together. And starches you find more in like potatoes, breads, cereals, beans, but they do break down in our system down to those more simple sugars, especially the glucose. Again, you'll find that in table sugar in your sweets. So let's talk about the role of the pancreas. The pancreas is a gland that is located right next to the stomach. It's just below the liver, and it makes not only some digestive enzymes that are pushed into the intestines to help us digest, but it also makes insulin in our beta cells. And it's constantly producing the insulin. We have a slow, steady amount that gets put into our bloodstream all the time, but there's also surges when insulin is secreted during meal times. And whenever the body senses that there's a high glucose level, well, it will send out some more of the insulin. And so your pancreas is critical to insulin being produced and working well in the body. And in type 1 diabetes, that function is decreased or absent. In the late stages of type 2 diabetes, which we're talking about more today, it still works, but you'll see that towards the end of type 2 diabetes, the end stages of it, you do see a decreased ability for the body to keep producing the same levels of insulin. Inflammation is one of the things that makes it decrease its ability to produce insulin. And so I used the word insulin, right? Insulin is a hormone in the body, and here's a kind of a picture of it. Insulin, again, is made in the beta cells of the pancreas, and diabetes happens when this molecule doesn't have as strong of an effect as it normally does. It's when its effect is limited. The cells become resistant to this hormone's effect, making it harder to signal the cells that it's time to let glucose in to the cells from the bloodstream. One of the things that blocks this, the effect of insulin, are something called free fatty acids. Free fatty acids, they're introduced into our system when we eat food, and it also is increased in our system or in our bloodstream when we're obese or when we're overweight. And I wanted to introduce GLUT4 transporters. So you'll see that in this picture, we have a couple things happening. GLUT4 transporters, I think of them like straws or hollow tubes that get put into, that can be moved in and out of our cell walls. And just like a tube or a straw, it lets the glucose get siphoned into the cell so that it can be used for energy production. They're not always there on the cell wall. They usually hang out in these things called vesicles that merge with the cell wall whenever insulin binds to the insulin receptor. So you'll see the insulin little red dots binding onto the insulin receptor, and that vesicle merges with the cell wall, and the GLUT4 transporter allows that yellow glucose to enter into the cell. And it's thought that the not only the free fatty acids they block that insulin ability to signal the GLUT4 transporter to move over, but it's also thought that fat buildup inside of our muscle cells, they call that intramyocellular fat. It actually kind of gunks up the machinery. It doesn't allow the GLUT4 transporter to move over to the cell wall as easily. And that's one of the thoughts anyways. And I wanted to introduce gluconeogenesis. And no, I'm not going to try to explain this diagram. There's about, I don't know, 40 different molecules in this and enzymes. But gluconeogenesis is the new production of glucose. And it happens often in the liver, but can also happen in our muscle cells. Let's say our muscle cells, they absorb a bunch of glucose. Well, it starts, if we're not going to start using that glucose right away, it packages it into glycogen. And so our muscle cells have lots of stores of glycogen. And when we need that energy, we start splitting the glycogen into its little pieces, which is the glucose. And then we start burning that and making energy from it. Glucose, interestingly, can also be produced from amino acids and the protein that we eat, particularly alanine, and that happens in the liver. The main production of glucose in our own bodies happens in the liver, and it sends the glucose out into our bloodstream. You'll see that there's quite a few diabetes medications that act on the liver. So I wanted to talk about, what would it look like or feel like to have diabetes, and wanted to walk through some of these early signs and symptoms in case you were wondering. In diabetes, we get a rise in the amount of glucose in our blood that travels along in our blood. And what this does is it causes us to be maybe a little more concentrated in our blood, and we lose a lot of liquid in our urine. So we develop excess urination. We then develop the excess thirst. We can sometimes have blurry vision with high blood sugars. There's something called acanthosis nigricans. It's a discoloration on the nape of the neck and also in the armpits and sometimes in the groin. I'll show you a picture of it next. And a lot of times, people have symptoms where they just don't feel quite right. They feel tired. And that's early on in the disease course. Later on in the disease course, you'll see tingling in the hands and feet, and you might even see weight loss. Whereas early on, you see a lot of people have obesity. And they lose weight because they're just not able to utilize the glucose that is so high in their blood vessels. And here's the picture of the acanthosis nigricans. It's a dark velvety patch found on the neck and on the armpits. You can sometimes see it in other diseases, including polycystic ovarian syndrome, and rarely things like cancer of the stomach or the liver. Now, if this was a little kid, you might think that their neck was dirty, right? You can just kind of wash it off. But and actually, I've had a patient before who thought, oh, my neck is always dirty. Why is it like this? And I can't seem to wash this off. And it's not. You can't wash it off. It's because it's a sign of insulin resistance, or the body's inability to react to the insulin that it has. Let's talk briefly about the diagnosis of diabetes. There's a couple other terms here. One is called there's a test called the hemoglobin A1C. It's abbreviated HbA1c. You can also check your blood glucose when you're fasting, or you can take a glucose tolerance test, where they essentially have you drink the equivalent of, I think, 1 or 1.5 Cokes worth of sugar, and then they look and see how high did your blood sugar go after you drank that, and that's a 2-hour test. There are other ways to look for signs of diabetes in the body, and that would be urine tests. A lot of times people with diabetes, if their blood sugars are over 200, their ability to reabsorb the sugar that goes into the urine is it just can't keep up with it, and so you start seeing sugar in people's urines. And there's the blood glucose, as I said, the blood glucose numbers, which we'll take a look at now. So this is the hemoglobin A1C. And imagine a blood vessel, and you've got little red blood cells traveling along through it. And along with that, you have a lot of liquid. You have some other cells that look for infection. You have platelets that help you clot. You have sugar or glucose traveling along with all those things as well. And that sugar, just to explain it really simply, is sticky, right? Syrup on the counter of the table, it gets really sticky. Well, there's actually an irreversible stickiness that happens with glucose in your bloodstream. And the glucose can become glycated or permanently attached to your red blood cells. And what we do is we draw some blood. We take some blood out of the finger or a vein, and we'll see how much glucose is covering that red blood cell. And so you'll see here on the far left upper corner, somebody with a low A1C, maybe in the normal range, only has a small amount of sugar molecules or glucose attached to it. Whereas somebody whose red blood cells have just been bathing in glucose, they have a really high level of diabetes. You'll see that the glucose is really concentrated on that cell. And what we get is a percentage. And the normal percentage is less than 5.5. And then from 5.6 all the way up to 6.4, that's considered pre-diabetes. And then anything over the percentage of 6.5, you would consider somebody having diabetes. And I say that this is a 3-month window look onto your diabetes or onto your glucose levels, because how long do red blood cells live for? Well, they live on average about 3 months. So you'll get some that are a little bit older, you'll get some that are newer, because your body's constantly recycling your red blood cells, but they live anywhere between 90 to 120 days. And so we look at that average, and the 90 days it gives us a 3-month picture or snapshot of what our sugar levels have been. And you'll see here that there's the excellent control, where it's anywhere between 4 to 6, good control in the orange, and then poor control, anything at 9 or above. And it also is summarized here as well, where the normal and the prediabetes and the diabetes range of the A1C is on there for you. Now, you can also diagnose diabetes by doing a random blood sugar. Anytime that somebody sticks your finger or you get your blood drawn for a metabolic panel and you're not fasting, doesn't matter if it's right after a meal or if it's any time during the day. If your blood sugar level is over 200, that's a really strong sign that you have diabetes. Now, if you're fasting and you haven't had anything to eat or drink other than water for the past 8 hours, and your blood sugar comes up at 126, that also qualifies as having diabetes. Now, there's that nasty test which they often make pregnant women do to check for diabetes. That's called the oral glucose tolerance test, and they have you drink, a Coke's, a full sugar soda drink's worth of sugar, and then they check you when you drink it, and also 2 hours later to see how high your blood sugar is, and you have diabetes again if it's over 200. So now that we have an idea about how it's diagnosed, I wanted to dive in and talk about treatment strategies. And I'll warn you here, there's a ton of medications that have come out for diabetes. And I'm going to go through the medications fairly quickly, honestly, because I don't use a lot of them. There are a few that I use, and I'll touch on those maybe a little bit more. But the fact of the matter is that a lot of these medications, they treat the high blood sugars, but they don't get rid of the insulin resistance or the insulin insensitivity, meaning that we're treating with these medications a symptom of the disease rather than the cause of the disease. And I'll point that out as we go through these. The first medication on the list here is something called the alpha glucosidase inhibitors. You might have seen the medication, or you might even be on the medication called acarbose. And what this does is it stops the breakdown of those complex carbohydrates, those starches. So when you have a potato and it travels down into your intestines, normally the starch starts breaking apart, right? But the inhibitor of alpha glucosidase stops the cleavage or the breaking down of that complex sugar into glucose. And so what happens is you just poop it out. And unfortunately, the problem with this is that a lot of people will develop GI issues with this medication. Just it's not comfortable that not having broken down the starches. And so you'll see flatulence, you'll see diarrhea, some people see constipation with this because your body is not absorbing that food component. So that's one of those medications that does help stop your body from bringing in such high levels of glucose, and potentially could help with weight loss, which would help the underlying problem. The next medication is called metformin, and is called biguanides, and the main drug there is metformin. Metformin's a great drug. It's one that I use frequently for my patients when they are first diagnosed with diabetes and even sometimes pre-diabetes. And what it does is it helps stop, I think, close to 30 to 40% of your liver's production of glucose. And so what it does is it helps stop your liver from spilling glucose into your bloodstream, when really you don't need extra glucose. You already have enough there. Metformin stops the high blood sugars, but it doesn't. It helps stop the high blood sugars, but it doesn't cause any lows, which is a nice thing about this medication. And this is one that I would recommend for somebody who has diabetes, with few exceptions. The next medication is called bile acid sequestrin, and this one medication is called Colesevelam. I know I just butchered that difficult name to say. This is an interesting medication because it not only lowers cholesterol, it also helps lower the glucose. How it helps lower the glucose, nobody knows. I'm sure there's a theory out there, but I don't believe that it's been proven. And so this is another class. Here is a medication class called dopamine 2 agonist. This is really interesting. It's not one that's commonly used, but it is used. And the main drug in this class is called bromocriptine. And the liver, one of the things that tells the liver to start spilling glucose, to start doing gluconeogenesis, breaking down the glycogen, is stress, the body's stress hormones. And our sympathetic nervous system, which is activated with things like caffeine or adrenaline, epinephrine, that will really rev up our system and cause our liver to start spilling sugar from into the bloodstream. And what dopamine agonists do is that they help decrease that sympathetic tone. So it almost kind of calms down the system and tells the liver, hey, take a chill pill and don't spill out so much sugar. And while this is nice, and this does help the system, it only has been shown to drop the hemoglobin A1C something like on average 0.27%. It's unfortunately it doesn't have a strong or a large effect on the system. So this is a medication that I don't normally use, even though it has a really neat effect on how it works in the body. The next medication here is called the DPP-4 inhibitors. The main drug in this class is called alogliptin. And what it does is it blocks the breakdown of GLP-1. And so what GLP-1 does a number of different things, but it helps slow down the digestion of your food. It increases the insulin secretion from your liver, from your pancreas, apologize, and it also suppresses glucagon secretion. Now, glucagon is another one of those chemicals that stimulates the liver to produce more glucose. And so I do like this medication, the DPP-4s, but there's an even better medication called the GLP-1 agonists. And those work on the receptors that GLP-1 does. And so rather than working so far upstream with the DPP-4 inhibitors, you can actually act a little bit closer to what you for the effect that you want using a GLP-1 agonist, and I'll show you that in just a moment. There's another class called the meglitinides, and the main drug in this class is called natglitinide. And what this does is it stimulates the beta cells to release more insulin. And so you take this before you would have a meal, and it just causes the pancreas to work a little bit harder. With medications like this and sulfonylureas, you start to worry about maybe stressing the pancreas a little bit too much. And there's a thought that you can kind of burn out the pancreas by telling it to work so hard. Uh, the next class of medication is called the SGLT2 inhibitors. The one that comes to mind for me is canagliflozin. Now, when your blood sugar is high, up at that 200 to 250 milligrams per deciliter range, and that's pretty high. And just to put it into context, I'm probably sitting around, I just had lunch, I'm probably sitting around 120, something like that. For a fasting person who does not have diabetes, normal range is, somewhere around 80 to 90. It should be below 100. And so when you are double that, up around the 200 range, you'll see that your your kidney is unable to hold on to the sugar that is in your bloodstream. So take a look at this picture here. On the left side, you'll see that there's a bunch of blood vessels going through something called the glomerulus in your kidney, and the glomerulus is taking the fluid from the blood and filtering it. And that fluid starts traveling down a long tube. You'll see it kind of courses up and then down through the loop of Henle, and it goes in a kind of a zigzag fashion down to a collecting duct, down into a larger portion of the kidney, goes down to the bladder, and then of course out of the body. And what SGLT2 inhibitors do is it stops the body from reabsorbing the sugar. And so what you'll see is that you're able to get rid of that high blood glucose, a significant amount, by taking this medication, because you're just peeing out all the sugar that was in your blood. I would say not all of it, but it can drop your blood sugars in a significant amount. One of the side effects of this medication is that people will have an increased number of urinary tract infections or yeast infections with this, because you have a lot more sugar in the urine or bacteria to feed on. Moving on to the next medication class is called sulfonylureas. And I've used this medication a significant amount. It's called glipizide is the main one. And it also stimulates the pancreas to just work a little bit harder to produce, to kick out a little more insulin, so that you have higher levels in your bloodstream. And it kind of forces the system to start lowering the blood sugars. I think this is a decent temporary medication for people with diabetes. On to the next class, and I think this is our perhaps our second or third to last one, so hang in with me here. This is called TZDs, and I'm not going to try to say the name, but what it does is it helps insulin work better in the muscle and the fat, and it reduces, again, the liver production of glucose. There is some debate with this medication whether or not it has led to more heart attacks. What it does is it does work at one of the causes of insulin resistance, and that is that it promotes fatty acid uptake. So those fatty acids that we have in our bloodstream, either because we're overweight or we just had a fatty meal, it helps absorb those into the body, which is excellent, because that helps make our cells more sensitive to the insulin that we're already producing. However, there has been at least one drug in this class that has been linked to heart attacks, so it's not one that doctors jump to quickly. All right, and as I promised, this is the GLP-1 agonist. Now, these are injectable medications that are not insulin, and one of them that comes to mind is dulaglutide, and what it does is it stimulates the GLP-1 receptors, slows down digestion, boosts the insulin release, suppresses the appetite. And because it suppresses the appetite, this also helps with weight loss. And so this is a great medication for those who are overweight and who have diabetes, because it has been shown to help with weight loss and helps one of those root causes, helps attack one of those root causes of diabetes and the insulin resistance. All right, so here's the next one. This is insulin. There are so many different varieties of insulin. There are rapid acting, short acting, intermediate acting, and long acting versions that last anywhere between that start at 5 minutes, and some of them will last all the way up to 22 hours, 24 hours. And what this does, of course, is it just increases the amount of insulin that's in our bloodstream, and it tells the cells that, hey, I need you to start responding to me because I have more of me here, and it kind of shouts at the cells to send over those GLUT4 transporters and allow the glucose to leave the bloodstream. The problem with insulin, and that many people will tell you once they're on it, is that it's a hormone that stimulates the storage of glucose. And so all you're doing is really packing away that glucose into your cells, kind of tighter and tighter. And unless you're burning off that glucose with exercise or activity, it contributes to fat accumulation and weight gain. And so if we can avoid it, I try to keep patients off of insulin, and unless they really need it to bring the sugars down. So that was it for the medications. Whew, that was a lot. So let me dive into other techniques for treating diabetes. One of those is surgery, and this is a picture of a sleeve gastrectomy, where they either do staples or they sew the stomach, a portion of it off, and they make it more like a tube rather than a big pouch. And so what this does is it limits the amount of food that you can eat at one given time, and it also has hormonal effects as well, which help decrease the risk of not only having diabetes, but it can help you prevent you from transitioning from prediabetes to diabetes. If you, it helps a lot with weight loss, and studies have shown that if you lose about 7% of your body weight, you can prevent yourself from having diabetes by about 58%. All right. So if that was making everyone tired, I want everyone to sit up for a second and wake up for this part. This is, I think, the most salient point that I can talk to you about today, and that's diet. Surgery is high risk. Each of the medications come with their own risks. If you want to prevent yourself from having diabetes or prevent it in your families, this is what you should know. Okay? And this is a study that was done on individuals who had diabetes, were already on treatment with insulin, meaning their diabetes was probably pretty bad. They were taking on average 26 units a day, which is a significant amount. And what they did is that they put them on a high carbohydrate diet with high fiber. So it means that they were eating fruits and vegetables and whole grains, and they were on a what's essentially a low-fat diet. Okay? And what they saw was that, and that by the end of 16 days on this diet, they saw that insulin was able to be stopped in 9 of the patients. And in 9 of the patients who were receiving 15 to 20 units a day of the insulin, and in 2 patients who were receiving all the way up to 32 units of insulin a day. The fasting blood glucose levels dropped in those patients on this diet. Yeah, even despite having the lower insulin doses. The cholesterol dropped by 2/3 from 206 down to the less than 150 on this diet as well. And what this is this is a whole food plant-based diet essentially, and this is something that we can all start implementing. Now, I want to add a caveat in here, and that is that any diet that decreases the free fatty acids should help decrease one of the root causes of diabetes. Okay, because it's that free fatty acid that is increasing the insulin resistance. And I want to talk about the keto diet. The keto diet, if you get enough weight loss on it, it can help decrease the free fatty acids. But the problem with the keto diet is that it's so full of fat, is that it increases the free fatty acid content in your blood. And you can see beautiful blood sugars on a keto diet, but it's not because the underlying cause is getting any better. It's actually potentially getting worse. What you're doing with the keto diet is you're treating one of the symptoms of diabetes, which is the high blood sugar, not curing the underlying cause. So I wanted to throw that out there and make sure everyone was clear that I don't recommend the high fat, high protein keto diets because they don't treat the underlying cause. They don't help the diabetes unless you have a really, really high and significant amount of weight loss. A lot of people, when they take a break from their keto diet and they have a high carbohydrate meal because they're going out to eat with friends or family, or it's not convenient, they'll see an incredibly high glucose surge because they haven't fixed the underlying problem with for their diabetes. All right, so on to the next slide here. And I realize I'm coming up a little bit closer on time, so we'll zoom through the rest of these. But exercise. Exercise does help with one of the underlying causes of diabetes. And what it does is that it sensitizes the cells for about 48 to 72 hours to respond to insulin better. It actually sensitizes the cells and reverses temporarily the insulin resistance. And actually, if you work out hard enough and you start breaking down enough of the glucose that are inside your muscle cells, there is a mechanism that causes that GLUT4 transporter to move over to the cell wall with an absence of insulin. So even without having any insulin in your body, you could still get some glucose to move into your cells to be burned by your muscles because you went and worked out. You'll notice that this is a temporary thing. So yeah, you should be working out every day to help sensitize the cells to insulin. Yeah, that's just an amazing thing that the body does. It makes a lot of sense. Again, weight loss will help decrease the free fatty acid levels in the blood and help decrease the amount of insulin resistance. So we've talked about the different levels of intervention to help prevent and treat diabetes. To help prevent the transition from pre-diabetes to diabetes, weight loss is key. Metformin can also be used. I normally wouldn't jump to any other medications during the pre-diabetes ranges because they're probably too strong and they're not meant for pre-diabetes. However, diet, exercise, and weight loss are great things to help prevent the transition from normal or even pre-diabetes to having diabetes. In closing, key underlying features of diabetes can be prevented by and treated with diet and exercise, including weight loss in there. And while there's a significant number of medications out there to help with the symptoms of diabetes, only a few actually help treat the underlying cause. So medications are really a help to decrease the negative effects of high blood sugars, but aren't out there to reverse diabetes, with some rare exceptions. One of them being the GLP-1 agonist really can help with weight loss and appetite suppression. And if there's one thing in your life that you're thinking about in terms of diet or exercise or weight loss, I'd recommend you have a chat with your family physician about it or your internist and see what you can do. Choose one thing today that you can change. Again, I'm a big fan of lifestyle medicine, focusing on the key behaviors that bring health towards us, rather than those that push health away. And to treat and prevent disease, you got to find the right balance of sleep, exercise, stress management, purpose in your life, finding meaningful relationships, and of course the big one, nutrition. And where can you find me? Again, down the road from C's Candy up on Foothill Boulevard in La Cañada. My office number is up there, 818-643-7128. I am accepting new patients, and if you're wanting to get screened for diabetes, we can order one of those tests for you. If you're wanting some guidance on the nutrition or medications for diabetes or even pre-diabetes, I'd love to chat with you. And with that, I'll go ahead and close and open up for questions.
Thank you, Dr. Compton. And everybody that's with us, the Live Well Senior Program members, if you'd like to type your questions in the chat, we'll try and get to as many of those as we can. Let's see, we have one.
Do you want to stop the recording, Melissa?
Yes, I do. Did you? Okay, yeah.